Sure.
Okay, good morning, everybody. Welcome to Department of Oncology Grand Rounds. It's my pleasure to be here with Dr. Danielle Rodin. Gave an excellent global oncology rounds yesterday, and we're really happy to be welcoming her for Grand Rounds this morning. Dr. Rodin is a radiation oncologist at Princess Margaret Cancer Centre and assistant professor in the Department of Radiation Oncology at the University of Toronto. She's director of the Global Cancer Program at Princess Margaret and the Director of Equity, Diversity, and Professionalism in the Department of Radiation Oncology. She's an elected member of the Board of Directors for the Union of International Cancer Control in Geneva. Her clinical interests are in breast cancer and hematologic malignancies, and she's a health services researcher with a focus on global access to cancer treatment and how patient, physician, and health system policies impact the delivery of high-cost and cost-effective care. Dr. Rodin received her BA from McGill, her medical degree from U of T, and her Master of Public Health from Harvard. She was the 2017-18 Harkness Fellow in Healthcare Policy and Practice in the Department of Health Policy and Management at the Harvard T.H. Chan School of Public Health. And there she focused on value-based care across international health systems. And I see that that's what you're going to be talking about. So welcome, Danielle. Thanks for coming to Kingston. Looking forward to your talk.
Thank you very much, Scott. It's a real pleasure to be here in person today. And thanks very much, Scott, for the invitation and everyone for joining this morning. I'm going to be speaking around this concept of what gets measured gets managed and how we can think about linking value and equity in cancer care. I know there are many experts here at Queen's in these concepts, and so really looking forward to the discussion today. My disclosures. So I'll start by explaining the concept of value in healthcare and talk about how we can identify drivers and consequences of overuse and underuse in cancer, and then end with a discussion about value-based programs and their impact on health equity. Now, the term value is used a lot in medical care, and if we actually go back to we actually look up what the term value means in the dictionary. The Oxford English Dictionary defines it as the importance, worth, or usefulness of something. But what contributes to value may be much more complex. And there are certainly experts in the field of art who have expertise in this determination. And they have valued the Mona Lisa at over $800 million. And I have no doubt that it may be worth every penny, but that's really a different question about whether it has value to us and whether we should buy it. There may be good reasons to buy such a painting, but we would really need to think about what's gained and what's lost from such a purchase. And so when we think about value in medical interventions, we say that an intervention has value when the evidence suggests that the benefit exceeds the harm, and when the added benefit is proportional to the added cost relative to the alternatives. And put simply, it's really the outcomes that matter to patients over the cost of that patient's journey. And underutilizing high value care and overutilizing low value care has significant impact on our system. It has physical, psychological, and social harms for patients, causes wasteful misallocation of resources in society, and deepens inequality, and contributes to the unsustainability of universal health coverage. And so all of this has culminated in what's been described as the moral imperative of value-based care. About 5 years ago, The Lancet published what they called the Right Care series. And the authors in that series wrote that because overuse and underuse are so deeply entrenched in contemporary medical care, and because the harms are so considerable, efforts to remedy these issues are a moral imperative and a political duty. Now, many of us here are familiar with the fact that healthcare costs are rising around the world. They've gone from $7.6 trillion in 2013 to $9.5 trillion in 2018. But what this graph doesn't show, again, is where and on what this money is being spent and what the value obtained from this expenditure is. In Canada, we're certainly not immune to this increase in spending. In 2021, we spent over $300 billion on healthcare, representing close to 13% of our gross domestic product. And this expenditure, we may say, is maybe appropriate. If we're actually achieving better outcomes for our patients. But there's an organization called the Commonwealth Fund, which does surveys of and evaluates health system performance across 11 different countries. And despite that high health spending that we saw in Canada, we actually place 10th overall out of 11 countries in our health system performance. And I think especially want to highlight that we placed 10th overall on equity. And I bring this up because this is often a point of pride for many Canadians in our healthcare system. But are we really achieving the kind of value that we're looking for with the money that we're spending? And within cancer, as many new interventions come online and become available, this is becoming an increasingly important question. As we invest in high-priced proton facilities, we have new high-priced cancer drugs. Again, are we getting the value that we hope? So in an effort to understand and address some of the rising healthcare costs, Dr. Berwick, who was the CEO of the Institute for Healthcare Improvement, proposed this wedges model of healthcare spending. And this dark black line at the top represents what he called business as usual. And so this is how national healthcare expenditures continue to rise if we continue spending the way that we're spending. And this dotted line at the bottom represents what he perceived to be a more sustainable level of growth in our national healthcare expenditure, which would match our growth in GDP. And these colored regions in the middle represent what he called the stabilization triangle, which represents different areas of spending reduction targets that could be reduced to eliminate some of the perceived waste in our system, waste caused by failure of care delivery, failure of care coordination, overtreatment, administrative complexity, pricing failure, and fraud and abuse. Now, one way to examine or elucidate the efficiency or appropriateness of spending is to look at variation in healthcare spending across geographic regions. And for more than 20 years, the Dartmouth Atlas has documented variation in how medical resources are distributed within the United States. And they published this analysis from 2014, which showed actually a twofold difference in spending amongst Medicare beneficiaries from the highest spending region, which was in Miami, Florida, to the lowest spending region in Anchorage, Alaska. And they tried to look at what was causing this big spread in variation. And some of that was due to overabundance of supply. There's certainly more hospitals, more availability of testing services, and variations as a result in practice patterns in Miami than there is in Anchorage. But they looked at a variety of different diseases and found that actually the outcomes in Miami, even after adjusting for the types of patients that were being seen, were no different than the outcomes in Anchorage, Alaska, across a variety of these different diseases. And so really suggesting that perhaps there's an element of inappropriateness of spending and inefficiency in the high spending areas. Now, I worked with a group in Boston to look at this concept of variation in breast cancer spending in the first year of treatment and in the last year of life. And we adjusted for the types of patients that physicians saw. So, do some physicians specialized in more advanced stage or higher risk patients. And even after adjusting for these types of patients, general indicators of the types of treatments that they prescribed, we found a 70% difference between physicians in the highest spending quintile compared to the lowest in the first year of treatment, and a 236% difference in the last year of life. And we tried to look at what was driving some of these differences in healthcare spending. And in the first year of treatment, we found that physicians had 77% more inpatient days, 36 to 38% more office visits and imaging tests, and 54% higher chemotherapy spending. And when we looked at the last year of life, there was 146% more inpatient days, 73% more office visits and imaging tests, 132% higher chemotherapy spending, and a 44% longer duration between the first day of hospice and death. we looked at this similar question in prostate cancer in the initial year after treatment and found that actually when we looked at variation between urologists, between the physicians and between the facilities, and when we looked at patients treated by radiation oncologists between physicians and facilities, we can see that for urologists, the contribution of patient and disease factors was just 1 to 2% in the overall variation that we saw in spending, and just 18% in the difference between radiation oncologists. And again, when we sorted these physicians into spending quintiles, we found that the highest spending physicians spent between 30 and 40% above the mean, and similarly for the highest spending facilities. And when we looked at, again, what was driving some of this variation, we found that the highest spending urologists had 30% more CT scans, more inpatient stays, and amongst radiation oncologists, and I wonder if those in the audience are surprised, 7% less likely to use brachytherapy and 500% more likely to use proton therapy. Now, again, we may say some of this higher spending is justified if we're actually achieving better outcomes for our patients. This was a study of patients with advanced cancer in the United States, and they looked at patients who lived in regions with the highest spending and compared them to patients living in regions with the lowest spending, and found no consistent relationship between living in a high spending region and having better survival across a variety of different cancer types, and shown here is non-small cell lung cancer, colorectal, and pancreatic cancer. Now, this is not to say that, again, that better technology is always a problem, but I think it does make us question whether and how we should be evaluating new technology that comes on the market to make sure that it is actually giving us better outcomes for our patients. This was a pair of studies that was published a few years ago in the New England Journal of Medicine, and those of you who treat gynecologic cancers may be familiar with them. And they compared minimally invasive surgery versus abdominal radical hysterectomy for early stage cervical cancer. One was a randomized controlled trial, and the other was an epidemiologic study. And they were published at the same time. And this is a quote from the author of the trial who said, minimally invasive surgery was adopted as an alternative to open radical hysterectomy before high quality evidence of its impact on survival was available. And the authors were actually surprised, not only did minimally invasive surgery not improve outcomes, but it actually led to worse outcomes for their patients. And they found that it led to a threefold increased risk of disease progression, a 10% decrease in disease-free survival, and a 6% decrease in 3-year overall survival. And when they looked over this period of time when minimally invasive surgery was being more widely adopted, they found that it was associated with an 8.8% per year decrease in relative survival over this period. So I think just an example of sometimes our haste to adopt new technology. And perhaps one of the most famous examples of sometimes less is more is this study by Jennifer Temmel, which was a study of patients with metastatic cancer that randomized between an early palliative care intervention and standard of care. And patients who received the early palliative care intervention had less aggressive care at the end of life, but actually longer survival. Now, we've been talking about a lot of the challenges of overuse over the sort of recent couple of decades, but actually this challenge of overuse is not new. And it was Leo Tolstoy who said, though the doctors treated him, let his blood, and gave him medications to drink, he nevertheless recovered. Now, we've been talking so far mostly about overuse, and I'd like to switch gears now and talk about this other concept around underuse of high value care, which has been defined as the failure to use medical interventions that are likely to improve the quality or quantity of life, that represent good value for money, and that are wanted by patients who are fully informed of its potential benefits and harms. Now, there have been 4 stages of underuse that have been described. This first stage of underuse refers to a total or partial lack of any access to healthcare, either because the system doesn't provide coverage for it or because of patients' unavailability to reach it or pay for it. The next stage is this health system, including the provision of effective and affordable interventions. Are they actually available when the healthcare system, when patients are reach the front line of healthcare delivery? And the third stage is this failure of clinicians to deliver or prescribe effective, affordable interventions. And the fourth stage is really this failure of patients to commence or adhere to effective, affordable interventions. And the effect of these four stages is cumulative. Once a patient has access to care, there can still be underuse at these sort of latter stages, either because of a lack of awareness, knowledge, or skill of providers, or other reasons, habit, inertia, time, inconvenience, because of the clinician or patient. Patients and physicians may have many reasons for either not accepting medical recommendations or ignoring evidence that they know exists. Physicians may have implicit substitutions of their own values and biases and place for the patients. And so again, these stages are cumulative and really compounded if physicians are busy delivering care that's either not necessary or not wanted. Access has also been, access and underuse has also been defined another way, and it's been called sort of this 5 A's of access. The first A is this concept again around availability. Is care available, the right type of care available for patients who need it? Second concept is around accessibility, which is the physical distance or travel time from service delivery point to the user. The third A is accommodation. So is care organized in a way that meets the needs and constraints of patients? Is it acceptable? So this is clinician acceptance of best available evidence, or also social or cultural expectations of individual users and communities. The affordability of treatment. Are patients protected from the economic consequences of treatment, and are the price of services compatible with the willingness and ability to pay of its users? And all of this really contributes to what's been called realized access. Now, those in radiation oncology may be familiar with this map here, which shows the number of radiation machines per million population. And this is a map that's been widely circulated. And it's actually matched here on this slide with the incidence rates of cervical cancer. And you can see that the areas in the map with cervical cancer incidence, the areas with the darkest pink are those regions with the highest incidence of cervical cancer, and are also the regions with the lowest availability of radiation therapy, and probably contributes to the fact that over 85% of cervical cancer deaths are in low and middle income countries. In 2018, Dr. Tedros, the Director General of the WHO, issued this response to the large burden of disease at the World Health Assembly, which is the annual meeting in Geneva of all the member states. And he really highlighted the importance of universal HPV vaccination and primary prevention in addressing this cervical cancer crisis. And he talked about how cervical cancer elimination has become this main goal, and that we can make cervical cancer a thing of the past. I'm certainly wouldn't dare say that vaccination and a focus on prevention is not hugely important. But what he didn't comment on was also the need to highlight effective treatment. And so we sought to understand what the impact was of scaling up HPV vaccination in low and middle income countries over a 70-year time horizon amongst 12-year-old girls beginning in 2014. And we looked at if all low and middle income countries adopted universal bivalent vaccination strategy, what would the impact be on cervical cancer incidence over time? And the challenge was that in the short term, by 2035, we saw only a 4% reduction in cervical cancer incidence. And even by 2072, when the first cohort of girls would reach 70 years of age, we would see only a 23% reduction in cervical cancer incidence. And that's because of population growth, incomplete coverage of the vaccine, and the long time lag from vaccination to take effect. And so we then estimated what the demand would be for radiotherapy during the same time period. What was the need for radiation? And the pink portion of the graph represents the number of cervical cancer cases that would still be in need of radiation. And the blue portion of the bars represents the vaccine preventable cases. And we can see that by 2035, we still have 9 million women in need of external beam radiation. And by 2072, over 38 million women in need of external beam. Brachytherapy, similarly, we see close to 7 million women still in need during this treatment by 2035. And over this longer time horizon, close to 29 million women. And in addition to the health benefits that are certainly needed of and the health impact of underutilizing radiation, there are huge economic benefits as well of underutilizing this treatment. And we looked at what happens if you treat women for their cervical cancer, allow them to return to the workforce and to their communities, and contribute to both the formal economy, to their caregiving roles, and also to the societal benefits of improved health and longevity, and found enormous benefits from an economic perspective of providing access and availability to radiation treatment. Now, once we've established the importance or challenges associated with the lack of availability of radiation, it brings us to this next question around accessibility of treatment. And this is a case study in Ghana working with a radiation oncologist there who was formerly a fellow at Princess Margaret. And we looked at what was the accessibility, so physical distance and time travel to access radiation. And the map with the concentric red circles shows the distance from the two cities where the radiotherapy is actually located. First, you can see this sort of 100-kilometer zone, 150 and 200 kilometers. And on the map next to it, you can see regions of radiotherapy utilization. And perhaps not surprisingly, those areas which are in the north and over 200 kilometers away from the nearest treatment facility have the lowest rates of utilization in the country, representing less than 6% of all cancer patients using radiation. Now, if we take this concept back to Ontario, we can go back to this additional concept of access around accommodation. Even if we make radiation available for our patients and accessible, there becomes this question about, is care organized in a way that actually accommodates for our patients? And are we meeting the needs of some of our more vulnerable patients? Ontario Health has sent out a survey, some of you may be familiar with it, called the Your Voice Matters survey. And this is a set of questions that goes out to patients where they have an opportunity to reflect on their recent clinic appointments at the cancer center and talk about their experiences. And these results were being sent to, these surveys are being sent to all patients following their appointments. We looked at the results of the Your Voice Matters surveys between September to December of 2020. So this would have been in sort of that second wave of COVID. And we looked at patients who were getting both virtual and in-person visits and found from that perspective, no significant difference, but regardless of visit type. But we found that regardless of whether it was a virtual or in-person visit, structurally marginalized patients were overall less satisfied with their care. Patients with higher ethnocultural composition scores where they lived found that their care was less culturally appropriate. Those with higher situational vulnerability scores felt that their discussion of their physical symptoms was less adequate. Those with higher residential instability felt that the discussion of their physical symptoms, their emotional symptoms was less adequate, and that the physicians often didn't spend enough time with them. Now, the fourth dimension around access was this concept of affordability. And this goes back to some of the sort of higher healthcare costs that we had seen. And, you know, one of the challenges with all the rising costs has been that these costs are not exclusively borne by the healthcare system, but are also borne by many patients in the system. And this concept has been popularized, and the term has been popularized as financial toxicity. And there was an article that was published in the New York Times, and they talked about some of the impact of financial toxicity on underuse of certain medications. And the author wrote here, the medical adjective for many patients, this term non-compliant, so patients who take less than the dosages of medication they were prescribed or skip appointments, procedures, or scans. And the medical term for their behavior, non-adherence, are insulting. These patients are not perversely refusing to follow instructions, nor are they failing to stick with their doctor's plan. They simply don't have the cash for the medicine prescribed. And, I think many of us can think about situations in our own clinic where patients, even here in Canada, are faced with these same challenges. Now, again, certainly one of the major contributors to financial toxicity has been this rising cost of cancer drugs. And spending on cancer drugs is actually the fastest growing component of cancer care overall and has far outpaced increases in medical care and prescription drugs generally. Competition has been discussed as an important market-based mechanism to reduce the cost of cancer drugs and as a way to sort of reduce overall spending on prescription medicine. And so we looked at from 2014 to 2020 how the price of cancer prescription drugs changed over time. And we looked at differences between brand and generic drugs being those that have lost their patent exclusivity. And you can find the dark blue line represents the mean. So we have the mean and the median cost of branded oral drugs. And the dotted red line is the branded non-oral drugs. And the two lines at the bottom represent generic oral and non-oral drugs. And you can see the enormous differences in how brands and generic drugs have increased over time during this period. And you can also certainly see why now many state laws and other regulations, including here in Canada, have promoted the use of generic drugs as a way to reduce overall expenditure. But, one of the big challenges is that there are limitations to competition and generic entry. We evaluated 185 different cancer drugs that were available during our study period, and only 18 of them actually lost exclusivity during the period. So, only a small number of cancer drugs are actually facing generic competition. And there are other factors that are contributing as well, concepts such as pay for delay, where brand name pharmaceutical companies are actually delaying competition by paying generic competitors to hold off on competing products. And actually it becomes a win-win for both the brand company and the generic, because the brand gives a bit of a kickback to the generic manufacturer for holding off on introducing their product into market. The other concept is this patent evergreening, where generally refers to the strategy of obtaining multiple patents that cover different aspects of the same product, typically by obtaining patents on improved versions of existing products. During our study, we also had many new biosimilars come online, and there has been, unfortunately, just a lot more limited competition with brand drugs from these biosimilars during this time frame. And although overall in the previous slide, we saw how generic drugs can sometimes are much lower than the cost of brand drugs, it doesn't always introduce competition the way we hoped. If we take the example of imatinib, where you can see the sort of vertical solid red line is when imatinib lost exclusivity. And you can see how the dotted red line is the price index for branded imatinib, and the dotted black line is the price index for generic imatinib. And certainly the generic drug is much lower, but actually what's interesting is that introduction of the generic drug didn't lower the brand drug price as much as you would think. And, a lot's been written about imatinib and why this may be. And one of the factors that's been discussed is sort of this concept of brand loyalty. Despite generics being available, patients and physicians still preferring the brand name drug. And the impact of these high drug prices are not limited to North America. This is an important study that was done from many folks here at Queen's, which looked at access to cancer medicine through a survey of a number of oncologists internationally, where they asked respondents about what the essential cancer drugs were in their region and what the impact was on financial toxicity and availability. And they found an enormous number of respondents reported that accessing these medicines placed patients at huge risk of catastrophic expenditure, particularly in low and middle income countries, and that this was all not just true for the newer high cost drugs, but also true for a number of older generic drugs. And of the top 20 listed, only dexamethasone was universally available for more than 50% of respondents. And this final dimension of access is that I was hoping to discuss today is this idea of acceptability. It's over 20 years ago that this report was published, Crossing the Quality Chasm, and they talked about how it now takes an average of 17 years for knowledge generated by randomized controlled trials to actually be incorporated into practice. And even then, application is highly uneven. And I think a really important example of that is in the use of hypofractionated radiation therapy for breast cancer. Many of us are all familiar with this important study that was published. This is the long-term results that were published over 10 years ago that compared conventional fractionation to moderate hypofractionation for breast cancer and found no difference in disease outcomes and no difference in cosmetic results. We then recently, a couple of years ago, did a survey of adoption of hypofractionation for breast cancer internationally. And we looked at a number of different clinical scenarios in the lumpectomy node negative setting, node positive, and post-mastectomy and palliative setting. And while there's quite good uptake of hypofractionation in the palliative setting, you can see huge variability in uptake in the non-metastatic setting. And if we look even here where at the lumpectomy node negative patients, the respondents from North America had quite good concordance in the use of hypofractionation. But if we look at respondents from Africa, uptake was just, or preference for it was actually just 40%. And overall uptake, again, was much lower in the other scenarios. We then asked patients what some of the barriers and facilitators to use of hypofractionation was, and found that one of the biggest factors cited as a barrier to hypofractionation was actually long-term evidence, which is really interesting when we think to the study that we just showed on the prior slide, where we have now decades of evidence on the use and multiple randomized controlled trials on the use of moderate hypofractionation. Now that's in terms of acceptability to providers. Acceptability to patients is another important factor. I've had the privilege of working with a fellow who's joined us from Zimbabwe and is an ASCO award winner and is looking for her ASCO project on the use of an acceptance of radiation, including hypofractionated radiation to patients in Zimbabwe. And she commented that, and from her own experience, that there isn't the same acceptance or around some of the evidence. And she said a lot of the prior studies of severe radiation-induced skin toxicity were actually conducted in high-income countries with often majority of white patients. And there's much more limited data on severe radiation-induced skin toxicity in Black populations, particularly in low and middle-income countries. And a lot of the standard clinical grading systems are not well validated in more pigmented skin. She postulates that some of these perceptions of severe radiation-induced skin toxicity may be limiting some of the adoption. And this is exactly what her study is going to be focused on this year. Now, a lot's now been written on ways that we can think about improving value-based care for our patients and for different communities. Elizabeth Kerr published this article in Health Affairs that talked about 4 different classes of ways that we can improve value-based care. The first is around targeted educational interventions and public education for patients and providers. And one of the most famous examples of this is the Choosing Wisely campaign, which I know many people here at Queen's are involved with, and is about publishing guidelines and recommendations for low-value services for patients. The second is around governance arrangements, organizational competencies, and delivery innovations. And at a global level, improving access to universal health coverage is one of the big ways that this has been discussed. Many studies have been done on behavioral economic interventions, written justifications in the online ordering systems, peer report cards to encourage, or maybe I should say shame providers into adopting best practices. And then adjusting financial incentives looking at payment model reform, coverage schedule reform, tightening indications with reimbursement, and sunset clauses for new technology. So when we adopt new technology, is this adoption and coverage contingent on actually generating the right kind of evidence to demonstrate benefit? Now, one of the challenges that's been recently described with a number of the interventions associated with a lot of these value-based reforms is that they haven't been designed with an equity lens in mind. And this is an example from outside the cancer space to do with heart failure. And some of the largest costs associated with heart failure and some of what was been perceived to be low value heart failure has been associated with inpatient admission. So there's been huge efforts internationally to reduce admissions from the emergency department associated with heart failure. And actually Medicare reports on 30-day admission targets, and these have been broad programs implemented here in Ontario as well. And this group in Ontario actually looked at the impact of a hospital admission reduction program for heart failure patients and found that although these programs reduced initial admission for heart failure, it actually led to much higher overuse of downstream health services in terms of repeat emergency department visits, death or other emergency department use or hospitalization from heart failure. And one of the comments is that there was really no prioritization of health equity in the design or implementation of these programs, not really thinking about how some of the patients presenting to the emergency department may actually be, in general, under users of the healthcare system. And so actually unintentionally perpetuating structural inequalities amongst historically low healthcare users in our communities. And so I think the next frontier around value-based reform is really going to be in this prioritization around health equity. I think all communities in the world today think about getting better value from healthcare. More health per dollar spent is certainly a challenge for all communities worldwide. And right now, there's really no convincing data that value-based programs have reduced inequity that affects marginalized populations, and in fact, has raised concerns that it can worsen disparities for these groups. And so when we think about how we can, in the cancer world, actually incorporate value in a different kind of way for our programs, I think we now have to have this explicit intention and goal of reducing disparities through these programs with measurement and evaluation at the core. So I think we have lots of time for discussion today. And so looking forward to it and looking forward to hearing your thoughts. Thanks very much.
So thanks very much, Danielle. That was a great talk. And some amazing work you've been doing. That last point you were making was very interesting. So just it'd be interesting to know about what your next, what do you think the next steps are in taking that step to better integration of equity into value-based care? What do you think are the most important steps?
Yeah, and I think it's a good question. I think one of the challenges has been that we haven't been thinking about health equity at all when we've been designing these programs. Even if we take, interventions like choosing wisely and we think about reducing, or eliminating some of the low value services, I think one of the challenges has been that there's been this focus on, reduction without sort of recognizing that not all reduction is helpful, that sometimes we have to think about, are there patients that aren't accessing healthcare at all, that we need to be bringing more into the clinic, that we need to be engaging more in conversations around treatment. And I think that having that as part of the design of whatever program we're implementing is actually going to be sort of this next step, that it really hasn't been in a major way part of the discussion so far, and actually measuring what the impact has been on value. If we were, a decade out from the initial publication and launch of the Choosing Wisely campaign, for an example, and most of these studies haven't been looking at that. So I think measuring the impact on equity and actually incorporating it into the design of these programs is going to be hugely important moving forward. Yeah,
I think it's important. It's interesting. One of our other major initiatives, Dr. Bates is leading. I'm not sure if she's online today. She is. It's something called Queen's University Improving Cancer Care, and Tara has a long background in quality improvement. But it's really we're on the verge of adopting a new information system here, And we have a strong background in health services with Hannah Booth Brundage et al., Dr. Wilson. And the idea is to make sure that we have a robust data platform in the region to identify disparities, but then to focus especially on the vulnerable groups that you're talking about, right? Because in this region, we know that there are a number of potential, what we think there are, I think we need the data, but elderly, more rural population, more smokers. So I think that's a very interesting topic. So maybe a potential for collaboration there, because improving equity and identifying disparities is a major part of that. Anyway, I've been talking too much. And any other questions in the room, or yeah, Michelle?
Excellent presentation, thank you, Danielle. I just wanted to know more about the hyperfractionalism trial and why it has not led to any change in practice. What do the guidelines say about it? Do guidelines play a role about it? And are they not changing practice because the guidelines are not telling them to change practice? A, and B, in MEDOC, guidelines play a big role, and the financial conflict of interest of people who write those guidelines has a huge impact. You did not talk on financial conflict of interest today, but I guess it's less of a problem in radiation oncology. That's my impression. Do you want to say something about it? And my final point is about the generics and biosimilars. I personally believe that most of our biosimilars are also cost similars. We expect them to reduce the cost of treatment, but they don't, as we anticipate them to. One problem is that, yes, they cost 10%, 20%, 30% less than the original molecule. But when the original molecule costs like $50,000 a month, even a 20% discount is more than $10,000 a month, which is beyond the reach of affordability for many patients in the world. So I think, like, my perception is that we should focus more on the launch price, so that the launch price is lower to begin with, rather than thinking of generics and biosimilars as a solution. I personally don't believe that they can be a solution, because the launch price is high to begin with. Yeah. So that's what they take that.
So maybe can I just repeat the question for the online audience? So Dr. Giawelli talked about the hypofractionation trial and the impact on guidelines and the role of financial conflict of interest, and then his perception of biosimilars, which he's coined the term of cost similars, and perhaps a focus on reducing the launch price because biosimilars have not had a major reduction in costs. And
yeah, no, those are great questions. So I'll start with your first question. Certainly, in radiation oncology, adoption of hypofractionation, I think there's been a lot now described on the impact of financial payment structure on adoption of hypofractionation. In a lot of systems where you're really paid per fraction, I think that's been a huge limitation to adoption of hypofractionation. Now, the survey that we conducted was self-reported, and we did ask about financial incentives. I think that wasn't highlighted as the #1 barrier, but again, that was by self-report rather than actually looking at what type of reimbursement system they were practicing in. The guidelines are quite clear on adoption of moderate hypofractionation, at least in the setting of sort of early stage disease. I think have been maybe not as clear in the setting of more advanced disease. And, I think it goes back to this other point around how long it takes for us to believe the trials that are coming out, how many trials are needed in order to convince us of the evidence. That study was done actually just before the Fast Forward trial, which looked at 5-fraction regimen, was published by the UK. And so a lot of our data around hypofractionation was around 15 or 16 fractions, particularly in the early stage setting. I think it will be interesting. There's been a much more cautious adoption in some regions of the world, particularly even in Canada to some extent, certainly in the US, around use of 5 fractions and in which patient populations we're comfortable with. So I think some of that is going to be around financial incentivization. I think some of it is around hesitancy in the guidelines. And some of it is around just our comfort level with accepting new data. And I think all of those things play a role. It was really interesting, though, that, that because that study was actually, our survey, I should say, was published before 5 fractions. 5-fraction use was not a big, was not widely reported in our survey. but still people cited lack of long-term evidence around use of 15 or 16 fractions, even for early stage disease. So I think we still have a long way to go. I think financial incentivization is part of it, but I don't think it's the whole answer. You know, around guidelines, as you probably know, when Choosing Wisely first came on board, one of the critiques of the campaign was that these recommendations were being published by professional societies who would publish these recommendations, some of which were around things that were not really being widely done anyways. So, you know, they'd have things, you know, you should not do some procedure, except the prevalence of actually doing that procedure in the population was maybe only 5 or 6%. So kind of low-hanging fruit for a lot of these professional societies. I think, you know, over time, we need to be thinking about, and I think people are thinking about actually publishing guidelines that are relevant and that can actually be impactful for patients. So I think that's sort of my answer to your first part of your question. On the second part of your question, so, you know, I agree with you, and I think that's been the challenge with some of these biosimilars is that, and there hasn't been the same degree of competition, at least historically, with these biosimilars. So even though there's a bit of a cost reduction, it hasn't been the degree of cost reduction that we'd really been hoping for with their introduction. I agree with you about launch price, but I don't think that's actually the only issue. You know, when I showed you those graphs of prices over time, you know, those prices, particularly around brand name products that have many years before they're eligible for generic competition, it's not just their launch price that's a problem, it's also their price over time. And I think now there's recent legislation, at least in the US, around trying to limit some of those increases, at least to inflation. And it'll be interesting to see how some of the legislation in the US impacts both prices in the US, but often internationally, because those initial prices do have kind of ripple effects more broadly. So I think it's actually both components that we need to be thinking about.
Really excellent talk, and congratulations on what you're doing, and thank you for what you're doing.
Thank you.
Yeah, I think it's a good point. I think launch price probably is part of the problem, but I also think Canada, or at least Ontario, has missed an opportunity with biosimilars. We've probably achieved 20 to 30% cost reduction, but in Scandinavia, by kind of aggressive, almost annual review and competition, they've actually reduced prices by 80% with biosimilars. Yeah, in Norway. So I think that. I think it's probably it's a complex issue, and then of course issues around even when you do you know, brand loyalty, etc. But with intravenous drugs, we can kind of overcome that a bit because it's usually we don't have a lot of choice once the choice is made. But anyway, so
and I'll add, you know, I think, you know, you could see that the prices for sure of some of the oral drugs were far outpacing the increases that we saw around some of the non-oral drugs. But you know, it's interesting. We even looked, I didn't show this data, but we looked at some of the factors that were impacting the sort of the effect of generic competition on price. And if you look at the number of AB rated alternatives for the drugs, you know, having competition increases or can lower the price, but then it sort of plateaus. So at a certain point, there's the more competition you have doesn't necessarily lower the price even further.
Yeah.
It's a cartel.
That's right.
Andy.
Thank you for an interesting talk. I was wondering, the discussion about hypofractionation. I think in some sites it certainly makes for a more efficient for treatment, allows for resources to be available. But at the same time, the flip side of it is we have introduced more techniques and more sites treated because of hypofractionation. Although you sort of have to add the SBRT to a safer sort of lung, early stage lung, brain FSRT. We treat a lot more of those sites or those patients that we would not have treated before. In order to investigate, you know, both improving efficiency and making research available, but the flip side is adding because of it.
Right. I mean, I think that the story around hypofractionation is not one story. And, I use the example of early stage breast cancer because I think that that's an example where there's very strong evidence around it, and sort of long-standing evidence. But I think that it's not, just saying we should adopt hypofractionation for everyone in order to increase capacity. I don't think that's necessarily the whole story. I think your point around, is it that we're just, using hypofractionation has allowed us to treat more patients? I think the question is, are we treating them appropriately? So if we're providing more access to patients because of hypofractionation, I think that's an important goal that we should be working toward. If it's allowing us to treat more patients in what we'd call sort of the gray zone of value, where, I think it sort of goes back to the it depends, then I think that's a different question that really needs to be studied and evaluated. In that survey, that initial survey that we published, we looked at breast cancer, prostate cancer, cervical cancer because of its sort of global applicability, and bone metastases. And we also asked patients around sort of different dose and fractionation they used, and certainly would not be a full consistent picture across all of those disease areas.
Thanks. I'm just looking online. Maybe if you have a question, if you could just raise your hand. Because we've had some great questions here, but happy to, if there's any questions online. Tim.
Do you want me to come closer to the computer, or do you think people online can hear?
I'll repeat it if, yeah.
Oh, okay.
Yeah,
All right. It's more of a comment, but thank you, Dan.
Well, yeah, why don't you come up then? Yeah.
All right.
If it's a comment, I don't want to, I don't, anything to be lost in translation. Yeah.
Yeah, it's easier. Thank you, Danielle. It's a fabulous talk, great visuals, and very clearly delivered. So it's incredible work. Congratulations. I think a big part that maybe you've illustrated is that change is hard. Thinking about hypofractionation and how we have, how can we have better evidence for shortening fractionation for breast cancer other than radiation? And here we are. The same can be said for single fraction for uncomplicated bone metastasis. I recently examined a student for a PhD degree in quality improvement, and I read their 350-page thesis on reducing the use of blood urea nitrogen testing. 350 pages on BUN, and the whole thing was about looking at this choosing wisely topic, and how could we actually reduce the use of that single test? You think, boy, that would be pretty easy. How could you even write that much on one blood test? But it illustrated to me on how complex quality improvement is, and maybe in some ways that's a bit of a missing piece for us as health services researchers. I think many of us don't have that strong quality improvement background, or we rely on maybe the easy things, throwing out guidelines and expecting that people might read them. And this particular thesis looked at using physician coalitions, using physicians gathered together around a key theme who are thought leaders in their individual centers, and using that to try to move the bar, which in that case was successful. But anyway, that more of a comment, but just that I think we need to figure out the how, and first of all, give your thought.
No, I completely agree with everything you've said. And I think that how piece is really what's going to move the needle on a lot of these issues. And I didn't go into as much detail today on some of the interventions, but I think as health services researchers, we really need to be moving more into this implementation science phase, where we're thinking about not just what we should or shouldn't be doing, but how do we actually, as you said, change practice, and change is hard. There's some interesting examples that have been described in the literature, when they talk about, and they've all had sort of mixed success. there's been some situations, and I was thinking about it recently. Princess Margaret recently just implemented Epic in June, and there was all this discussion around, can you embed sort of forcing functions into the electronic record? And there's a publication of how Cedars-Sinai in the US had implemented some of these choosing wisely recommendations into their EMR, where you had to actually justify particular practices and sort of and actually showed a reduction in some of these practices that they were looking to eliminate. But I think sometimes you get clicking fatigue and other factors. So I think we need to really be studying this and thinking about it. Certainly in the US, there's been a big focus on different payment models that are ways to reduce. I think a big target of them is actually reducing spending. I think we need to be really thinking again about how do we maintain quality with them, and how do we again ensure that we're not inadvertently causing harm to some of the patients who physicians may prefer not to take on in their practices. So I think we need to be really thinking and moving much more into this implementation science space. So completely agree with your sentiments.
But I think that's an important point on using the technology. I mean, just to the point you brought up to him about ordering, like you can't, DUN is not something that's easy. You can't order it anymore. AST you can't order, but more just to bring it back to our other discussion, we can argue about the dose reduction with biosimilars, but as a medical oncologist, I can't order originator bevacizumab anymore. I can only, there's a couple of options, but I can only order biosimilar bevacizumab. And has that ever happened in radiation oncology where you have to order that there's a force order for something where there's evidence? Okay, yeah.
Oh, no, go ahead, Tim. Sorry. Yeah.
I was just gonna say, we've just embarked on the quality-based procedures for radiation oncology in this area. So we have protocols that are specific to the kind of treatment we want to deliver, but they're still very broad. So you can hit, but pressures could be applied.
Yeah.
Yeah.
Okay, great discussion. I'm just looking at the online. Okay, well, great discussion. Thanks everybody here. Thanks everybody online. And thanks so much to Dr. Rodin for coming to Kingston. Great talk. And as Michelle said, thanks for the work you're doing and thanks for sharing it with us today.
No, thank you so much for having me.
Yeah.
Thanks so much for the great comments.